Mhm. Let's solve a question. The question is, a 30-year-old woman presents with a positive rheumatoid factor. Let's go to the question. Where is the question? Yep. So let's take a color. Let's pick the width. Okay. The question is, a 30-year-old woman presents with a positive rheumatoid factor. How will you evaluate her? How will you evaluate her? So first of all, let's get the differential straight. What are the differential diagnoses of a positive rheumatoid factor? First of all, rheumatoid arthritis, RA. And a similar condition to RA is Sjogren's syndrome, which oftentimes may be secondary to RA, but sometimes can be primary. So RA followed by Sjogren's syndrome, and then it could be SLE. In SLE, you have a lot of antibodies, and RA or rheumatoid factor could be positive in SLE. Now, what are the other conditions that can have a positive rheumatoid factor? You have few diseases to specific organs, such as in heart, if you have infective endocarditis, then it can lead to a positive rheumatoid factor. If you have primary biliary cholangitis or primary biliary cirrhosis, PBC, this can lead to a positive rheumatoid factor. And then if you have cryoglobulinemia, which is mixed essential cryoglobulinemia, which is commonly associated with hepatitis C infection, that can also cause a positive rheumatoid factor. Additionally, among the infectious diseases, tuberculosis may lead to a positive rheumatoid factor. So those are the differentials for this case. Now, what are the clinical history we can take? That's very simple. We have to just go through the specific common features of each of these conditions. So let's have the history, and then we'll have a clinical exam, and then we'll do some investigations. So what are the histories for rheumatoid arthritis? Very simple. Let's take a different color. For rheumatoid arthritis, there is involvement of the small joint. So small joint involvement, there is symmetrical small joint arthritis associated with morning stiffness. So symmetrical, small, and stiffness. And this can be associated with a low-grade fever. For Sjogren, there will be dryness. There will be dryness in the mouth, dry eye and dry mouth. And there could be low-grade fever, and there could be some joint pain. So could be some joint pain. Even there could be eye pain or redness due to conjunctivitis. For SLE, the classic symptoms are oral ulcer, there could be malar rash, there could be photosensitivity, and there could be joint pain. For infective carditis or endocarditis, there will be fever, there will be palpitation and shortness of breath. So those are the classic symptoms of infective endocarditis. For primary biliary cirrhosis, there will be jaundice, and there will be severe fatigue along with itching. So itching is a classic symptom of primary biliary cirrhosis. For mixed essential cryoglobulinemia, this can be associated with some rashes on the body. For TB, you can have low-grade fever, you can have wet loss, and if it involves your lungs, they can have cough and you can have hemoptysis. And if it involves the spine, this can cause pain, and this can lead to fracture, pathological fracture, even features of spinal cord compression. So those are the histories. Now let's go for the basic or most important clinical exam findings. In rheumatoid arthritis, what you'll find that there will be features of joint tenderness, there are features of arthritis, there will be joint tenderness and swelling. We'll find, sometimes you'll find rheumatoid nodules, and there will be some deformities such as Schwanneck deformity, Bottonia deformity, Z deformity, and ulnar deviation of the fingers. For Sjogren syndrome, we will find there will be enlargement of the salivary glands. So salivary glands will be enlarged, the eyes will be red, and there will be dental caries. There could be lymphadenopathy, and there could be features of a Raynaud phenomenon. So let's write Raynaud. For SLE, the same features, you can write them down again. You will have the malar rash, and if you examine the oral cavity, you'll have the oral ulcer. You will have the classic features of it, the rashes. You will have alopecia. And in some cases, this can have a Raynaud phenomenon. For infective endocarditis, the most important features are found in the fingers. So the finger features such as the osseous node, genoelation, splinter, hemorrhage, etc. And the eye, you will find the rot spot, and you will find the classic changing murmur or new onset murmur in your heart exam. For primary biliary cirrhosis, you will find the same features. You will find the itching leading to the scratch mark. You will confirm the jaundice, and you might find a hepatomegaly. For mixed essential cryoglobulinemia, you can find the rashes, as I mentioned. For TB, the findings could be varied. You can find the evidence of pulmonary tuberculosis on your chest, and if there is pus disease, the spine will be tender. So those are the clinical exam findings that may be found in patients who is rheumatoid factor positive. Then let's go for investigation. The umbrella investigation for us would be CBC with ESR. And in CBC with ESR, if there is active inflammation in rheumatoid arthritis or Sjogren syndrome, there will be increase in neutrophil count. If there is lymphopenia, this might suggest SLE. If ESR is high, but CRP is normal, this goes in favor of SLE and Sjogren syndrome. Then for RA, we'll do the ACPA, anti-citrullinated peptide antibody. ACPA will confirm, that's a different color. This will create something. ACPA, this will confirm the rheumatoid arthritis. For infective endocarditis, we will do the blood CS, and we will do an echo. Those will help us diagnosis of infective endocarditis. For primary biliary cirrhosis, we will do the liver function test, including the serum bilirubin, and we will also do the ALP and ALT, along with the ultrasonography of the hepatobiliary system. For mixed essential cryoglobulinemia, what we can do an anti-HCV antibody. And for TB, we can do the classic investigations such as sputum for AFB and GeneXpert. We can also do the chest X-ray. We can also do an MT. And if there is involvement of the spine, we have to do an MRI of the spine. So that's all. That's how we systematically evaluate a woman who has presented with a positive rheumatoid factor.